Welcome. This session is the first of the concurrent sessions, and here we're going to talk about innovations using technology. There are 4 presentations, each will be about 12 minutes, followed by 3 minutes for questions. When we get to the question session, please come to the microphones down here in the front so that we can make sure that everybody can hear your question and we get a full response. The first presentation is going to be from Stephen Manley, who's the Acting Cancer Services Innovation Manager at Mid-North Coast and Northern New South Wales Local Health District. And he's going to talk about electronic fax and internet conferencing technology to enhance communication between cancer services and primary health care providers. Welcome, Stephen.
So thank you very much. So thank you to Cancer Institute for the opportunity to come and present today. I'm also joined by Klaus Darrow, who's the Information Systems Manager for the North Coast Cancer Institute. Klaus is based in Coffs Harbour but covers the oncology services provided across the 2 LHDs. And this presentation is going to be a brief overview of the project, which is still in a formative stage. In this morning's presentation, I'll provide some background to the program from which the project has been funded and aim to give you a good idea of the project's objectives and scope. I'll also give you a brief background of the key stakeholders and our clinical settings, which I'm sure each of you will be able to relate to. There are 2 photos on this slide from Uluru, one a very familiar view of the sun setting on a cloudless autumn day, and the other of some rock art in one of the many caves within Uluru. I've added these here as an analogy for the project we're working on now. Uluru has many uses, and one key use for thousands of years has been communication. It contains many natural auditoria where key information is shared to various groups by word, by demonstration and through art. What we are trying to do now on the North Coast is the modern equivalent of this, using the most appropriate media to deliver the relevant information to the people that need it. And whilst we aim to innovate in our provision of cancer care and treatment, we should always ensure we leverage off those that have gone before us who did not have the advantage of instant messaging but were still able to get their message out nonetheless. And okay, we're away. Cancer Institute New South Wales has identified primary health care as an area of the New South Wales health system where there is potential for growth and improvement in cancer control. It is also a sector where there is a significant history of innovation and collaboration, so it is well equipped and experienced to take on a more deliberate role in cancer control. The Primary Health Care Grants Program aims to build on these innovations. Under this program, projects are identified and developed to design and implement innovative programs to improve the communication between cancer services and primary care, or further build on existing communication improvement programs. Primary Healthcare Grants Program is anticipated to allow the application of locally developed innovative models and strategies to other settings where appropriate, and an expression of interest was used to identify organisations to undertake a project of up to 12 months to improve collaboration and communication between primary care and specialist cancer care services. This process provided the opportunity for organisations or collaborative partnerships to either design and implement innovative projects to improve that level of communication or enhance communication projects that were already underway or implemented. And I understand that the New South Wales Health Minister will be here a little bit later to talk about some other successful grants from that program. A collaboration between North Coast Cancer Institute, a specialist public cancer service, and North Coast New South Wales Medicare Local, the primary healthcare organisation, was successful in gaining funding for a project to implement e-faxing and internet-based conferencing technology. The project will leverage off existing technical capabilities within the oncology medical record mosaic, as well as utilising existing IT infrastructure, including hardware, software and network architecture. Electronic faxing will greatly streamline and simplify communications and reduce paper-based processes, thus decreasing our carbon footprint and reduce the laborious burden of manual paperwork placed on administrative staff. Internet-based video conferencing will further improve communication and collaboration, provide benefits in terms of education, telehealth, and improve patient care in rural and regional areas. Combining both technologies will deliver an innovative model of multidisciplinary, coordinated care by further developing and enhancing clinical service networks in rural and regional areas. These technologies will improve the experience of people with cancer and their carers, giving healthcare professionals vastly greater opportunity to share patient information. Project funding will be used to supplement the IT infrastructure as well as for end-user equipment like webcams, tablets and laptops. We might go to eBay and see whether we can save $1 there as well. Required software applications, user licences and training will also be provided within the projected budget. There are two main stakeholders representing the end users within this project: North Coast New South Wales Medicare Local and North Coast Cancer Institute. Medicare Locals are a national network of primary healthcare organisations, and they build on the work of the divisions of general practice networks. The North Coast New South Wales Medicare Local is a not-for-profit organisation that came into existence as part of the Commonwealth Government's health reform package. It was established through a partnership between Hastings Macleay General Practice Network, Tweed Valley General Practice Network, Mid-North Coast Division of General Practice, Northern Rivers General Practice Network, North Coast GP Training and Many Rivers Aboriginal Medical Services Alliance. This new organisation has strong links to our local communities, health professionals, service providers, consumers and patient groups. North Coast New South Wales Medicare Local has a vision of creating better health for North Coast communities and is responsible for making it easier for patients and service providers to navigate their way through the healthcare system. North Coast Cancer Institute provides radiation oncology, medical oncology and haematology at Port Macquarie Base Hospital, Coffs Harbour Health Campus, Lismore Base Hospital and a medical oncology and haematology service at the Tweed Hospital right up there on the border. There are also several smaller hospitals providing consultancy and or chemotherapy services in each of the local health districts that make up the North Coast region. The main electronic medical record linking the four main sites is Mosaic, which provides treatment prescribing and recording as well as practice management functionality. Each of the NCCI sites has video conferencing facilities, allowing staff to link with each other and also externally. NCCI has a strong record in implementing innovative cancer services and has expanded rapidly since 2007. This is envisaged to grow further as new public MRI scanners and a PET-CT scanner will reduce the outflow historically seen from regional centres to metropolitan centres and will continue to attract the broad range of specialist clinicians that are required to deliver the right care in the right place at the right time. Australian Bureau of Statistics estimations and New South Wales Health Population Projection Series show that there are currently approximately 515,000 residents in the North Coast region of New South Wales, and overall population is projected to grow to 543,000 by 2016, and this is slightly higher than the New South Wales average. Of more significance to cancer service planning, though, is the projected population increase in the 65+ age group, which is expected to grow by 20% by 2016, and this is 5% higher than the New South Wales state average. The region has many rural and regional population centres and varied topography, resulting in a dispersion of population with specialty services only at the four main hospitals. And you saw that in the maps that have been up previously. There is no uniform communication infrastructure or processes to link all of the various clinicians at the point of care, i.e. at the specialist centre, in the GP's clinic or at the patient's home. There are many practice management solutions in use, with many opting to use a system that meets the majority of their service requirements. Furthermore, paper-based processes are outdated, costly and limit the ability to effectively share information and provide quality care. These multiple systems in public and private settings are difficult and costly to interface, and the project's proposed solutions bypass much of those barriers. Primary care providers do not always have the opportunity to give input to care management plans in the multidisciplinary setting. This is a disadvantage to the GP, also to the specialist and the patient, and can inhibit the holistic management of the patient. There is often a lag in communication from the specialist centre to the primary care provider when acute treatment is planned or completed, i.e. that discharge or follow-up information. The result is that all service providers end up feeling less engaged. Change management issues also associated with major changes from paper to electronic are challenging, as are any change in practice for busy people and service providers. The solution being implemented through this innovative project includes optimising the use of modern technology to enable clinicians to engage in the manner that they wish. It is not all about technology, but getting the best value out of our existing systems and value-adding key pieces of equipment will enable the shift towards optimal patient care, regardless of their address or the point of care. Microsoft owns Skype and Link, and these are to be integrated as part of a national program. This will allow better connectivity between key stakeholders who can function with their application of choice, thus reducing the training burden and hopefully increasing engagement and building sustainability. Another key advantage will be the integration with the Tamberg video conferencing system that is in use across the New South Wales health facilities, allowing Tamberg users and then Link users to join in video conferencing together. Argus secure messaging, desktop eFax technology and software, webcams and tablets or laptops with wireless connection will all be part of the technical solutions. Citrix Remote Gateway will be implemented to allow remote access to Mosaic Oncology medical record, and other resources such as PowerChart. So what needs to be done first? Well, new hardware, software and licenses need to be implemented to run MS Link and e-faxing. Training of staff in any new technology and also in the processes to ensure that the technology enables them to gain benefit. Establish change management processes to enable big changes in the work practices and, where necessary, sell the benefits and get positive engagement from all parties. And what are the benefits? Well, face-to-face consultation between GPs and oncologists from office to office, from office to MDT meeting, or bedside to specialist. Anybody think of any others? There'll be plenty, any time that you want to have that connection. Patient clinical consultations using MS Link technology and GP preferred Skype. Remote access to MDT meeting for a number of clinicians, enabling them to input to care management plans, but also hear firsthand what that plan is, and therefore provide consistency and confidence to the patient, as the patient will then know that all their caregivers are working in concert as close as possible to real time. EFAX and Argus will reduce the administrative burden of having to deal with snail mail and manual paper handling, and clinicians will be able to receive and send documents electronically, such as referrals, MDT plans and follow-up plans. Furthermore, there will be staff professional development through involvement in external MDTs and education opportunities, and the chance to observe a wider range of activities than they might otherwise have physical access to. And patient benefits. Well, all of this is primarily to improve patient care and provide the right care in the right place at the right time. But a more granular look reveals that point of care service will result in the clinician interaction where the patient is. For some cases, this is restricted due to disease-related or comorbidities, travel, carer or other restrictions, so it will be possible for certain patients to get a higher level of service without the need to travel to a higher level service provider, incurring costs through pain, travel or hospital admission. Now, for some, all this spells out more work, more time required and more costs, but this is about innovative solutions providing efficient and optimal practice, i.e. less time doing the non-productive activities and more time to do the valuable activities that specialised staff are there to do. The scope of the project may not allow for all of these to be realised initially, but once the infrastructure and processes are in place, then many more should be able to leap forward from the spot that we get to. So where are we now? Well, in Lismore, a video conferencing clinic has been established for Associate Professor Tom Shakespeare, who is based 3 hours south in Coffs Harbour. Referrals are received electronically and patients present to Lismore to have a face-to-face consultation with Tom's Lismore-based registrar, and then has the video conference consult with Tom as the specialist. All in a consulting room so that the registrar and any other clinician based in Lismore has access to what they need for the patient, whilst the administrative staff continue to run multiple clinics for a number of consultants without any disruption associated with that particular consultant not being there physically. Patients that must see Associate Professor Shakespeare are scheduled to the clinic when he is there in person, and for the video conference clinic there is a saving of 6 hours travel, and for those of you that know the Pacific Highway, 6 hours driving on that is a big saving, and no delays to the patients in regards to when they can be seen and what level of care is going to be provided. Local work groups are being established with consultants from each of the 4 main specialist treatment centres and GPs in each region. The early goals are to get some keen, engaged stakeholders to deliver some quick wins and build momentum towards the broader and potentially more challenging tasks. MS Link is planned to be implemented within the LHD's IT infrastructure in the next 8 weeks. The most immediate steps are to continue the project plan fine-tuning through our established steering group, acquire the necessary IT hardware and software and have it implemented, and work with those local pilot groups so that we can robustly test some theories and establish some class solutions to roll out more broadly. We want to link with other projects. As I said earlier, we want to learn from the experience of others that have gone before us, but also benefit from the work that's being done around us so that we are all contributing to a better holistic solution. Sustainability, this is a really key issue. It's important that not only the current staff and users of the system get involved and trained and understand what to do, but the system then needs to be maintained. New staff need to be orientated appropriately so that we don't just have it fall over after a year when people have moved on. What we want to do is make sure that the old comfortable way is archived and the new innovative way is the only way to go. So we're all keen to see what the NBN will bring us and how we can utilise that. So watch this space.
Thank you. We have about 1.5 minutes for questions. Would folks like to come to the microphone? Any questions for Stephen? Sancha.
Stephen, have you got patient feedback yet on Tom's clinic?
No, thanks for asking that. That is something that we're establishing at the moment. We're a little bit early days. There's a model that was used up in Townsville for a much broader outreach service that we're using to try to get that information. Anecdotally positive, but nothing quantitative to report as yet, but we will be feeding that in.
And I'd like to ask a quick question. What metrics do you plan to use to monitor this over time?
Klaus, would you like to field a question?
Yes.
We haven't really thought about that in detail, but I would imagine some sort of assessment that we can utilise within our existing electronic system that we ask the right question and then use the statistics from there.
Do you have any suggestions? Because we're here to learn as much as we are to spruik.
It strikes me that since this is an electronic system, you want to make sure that the measurements or the metrics can be derived from the data that you're already collecting, or that the data elements are being added into the system. Efficiency, the number of contacts, with especially contacts, and then the improvement in access to care are your main metrics or outcomes that you're looking for. So I would look towards, you might also, for example, use number of faxes, number of video conferencing sessions, et cetera, at least as a starting point.
I think there was another question.
I just wondered how you're going to address encryption issues with your fax transfer of information, or whether that is an issue for you, or whether you've got some software or technology that you're using specifically to address those issues.
Thank you for that question. I'll throw that to Klaus as well.
We're mainly trying to use Argus. Argus is a secure messaging service that's been in place for some time, and it's widely used within our area, and I think it's also used elsewhere in New South Wales. And it's also already interfacing with the existing PAD systems on Power Chart, and we're going to actually leverage that use as much as we can of that particular technology, which encrypts the data both ways.
Thank you. Thank you, Stephen.
Great, thanks.
Our next presentation will be Deirdre D'Souza, who's the clinical coordinator of the Cancer Care Pharmacy at Westmead, and she's going to talk about getting wired, implementation of an integrated electronic cancer patient management system, CPMS, at Blacktown Hospital.
Thank you. I might just explain what the Sydney West Cancer Network is. It's a network involving 2 local health districts and includes 2 comprehensive cancer centres at Westmead and Nepean, a smaller centre at Blacktown, and services at Mount Druitt, St Joseph's, Hawkesbury, Blue Mountains and Lithgow. And the network also has linkages with the private sector. So before I talk about the CPMS, I'll tell you a little bit about the X-File, which is where all this started. The X-File was a specific cancer patient file that was initially developed for radiation oncology patients at Westmead, in addition to the medical record. It was formatted as a fold-out flow sheet with entries by column and a front page for history and treatment plan. And the benefit of the X-File was that it was easy to review and document on a paper system, an extended and complicated treatment journey. In 07-08, we had network expansion and amalgamation, which led to a merging of the RADONC and the MEDONC X-Files at Westmead. At that time, there were over 3,000 active patient files at Westmead alone. And we soon had operational difficulties with tracking and timely access to the X-File due to concurrent demands. It was not uncommon for the same file to be wanted for chemo write-up, clinic review, trial screening and admin filing. Not all staff followed correct booking out procedures, so our admin staff turned into detectives, sort of hunting everyone's desks for all these missing X-Files. And we ended up like a hybrid of 2 television shows there. But this issue was creating critical patient safety and impacting staff morale. And as a few years earlier, a pilot of a prototype e-cancer patient management system at Westmead had demonstrated feasibility, a risk management decision was taken in late 2008 to explore the available options. A task group comprising senior clinicians, nurses, scientists, and allied health staff was formed to identify facts and seek solutions. Advice from area IT and New South Wales Health was sought, and network stakeholders were consulted to develop the system specifications. These were measured against software programs on government contracts, but we found that whilst these programs were capable of supporting RAD-ONC requirements, major workarounds were needed for med-onc, clinical haematology, and other cancer services. Additionally, different RAD-ONC software were licensed at Westmead and Nepean at the time, and it was therefore decided that the CPMS project would not be intended to replace the contracted RAD-ONC functioning software. A statement of requirements was developed, and the task group reviewed 6 eCPMS systems over 2009-2010. Charm Health, which is an Australian-developed CPMS system, was selected in 2010 through a tender process. So the aim of CPMS was to implement an integrated electronic cancer patient management system to improve patient care and to support and streamline workflow practices for the network. A pilot phase was planned at Blacktown Oncology Unit. A project team was established to drive the implementation, and a project support officer was provided from the vendor. We started by mapping out the network's functional requirements, which involved understanding workflows of our current practices within and across cancer services and the changes we expected from the CPMS. Liaison occurred across our 3 main sites, and small user group workshops were held where we did our workflow mapping. And these are some of the more presentable workflows you can see on the screen. Most of them were just on reams of butcher's paper. 4 super users were appointed who underwent project officer training at Charm Health. At the same time, we had to plan for the technical side of things, and this involved working with our IT department and the vendor to scope data volume and server requirements and ensuring redundancy was built in. 6 Citrix servers were needed to cover the network. Planning for the PAS interface was a little bit more difficult. This is the upload of patient information from the hospital IT systems. Department of Health IT policy did not allow direct queries with outside systems, so the interface had to be established via broadcast messaging and storage of data. We also explored interfacing and licensing arrangements with other existing software systems. Unfortunately, the pharmacy dispensing system, iPharmacy, does not allow interfacing with any other external systems, but we were able to set these up for the billing and correspondence systems. MIMS and EviQ access was enabled, and downloads through Cerner PowerChart were also set up. System testing occurred using a test version of the CPMS until just prior to go live. As there was no iPharmacy interfacing, significant manual data entry was needed. The drug formulary was restricted to cancer-related treatment and supportive cares, and we reached consensus across our 3 sites about what the formulary would include and what the entry format would be. 551 items were added. Westmead was the only site with chemo production facilities, but these production sets still needed to be set up even for external chemotherapy outsourcing. EviQ was accessible through the CPMS, but it was a read-only version and there was no uploading of protocols. Therefore, treatment protocols, or pathways as they're called in the system, had to be manually set up. Consensus on the priority protocols across the sites was obtained, and 253 of these were added. Other data entry included user assignments, GP information, and resource details. And verification processes were set up for all our data entry. The Blacktown Oncology Unit services one of the fastest growing geographical populations in New South Wales. It provides an integrated and coordinated MDT ambulatory service to local cancer patients. The unit has a large treatment room with 10 chairs and 2 beds, and it was our preferred site for the pilot, as unlike Westmead and Nepean, they did not have an electronic scheduler and were relying on a paper booking system. All the consultants were based off site, so notification systems were fax-based. They did not have a chemo production service, and they had a small but very motivated team. Staff training was done by the project team and with support from the vendor liaison officer. And we have to say the hardest group to train and to access were the doctors. Our pilot launch date was almost exactly this week 1 year ago. We had a delay as a last-minute hitch with the PAS interface broadcast messaging, so we had a few late nights spent manually entering current patients and treatment plans into the electronic system. We had on-site staff support available for the first few weeks of the pilot as well. So going on to our outcomes. So before, the unit actually relied on a paper-based appointment system, as I mentioned. The staff tell me this is a picture of pretty much what the diary used to look like. We weren't able to find it and suspect that someone's actually had a ritual burning, so since we introduced it. But obvious problems arose with legibility, missed bookings, overbookings, problems with sticky notes when two people were taking a booking for the same time slots on different phones. Pages fell out, notes fell out. Drug wastage occurred if cancelled treatments were not crossed out in the diary. Although there were limited chairs and beds in the units, because of the overbookings, the nurses often had to pull chairs out of the waiting room and stick patients in the middle of the room to treat them and stay back to finish these treatments. Missed bookings also meant the drug was not ordered or charted, and patients had to be turned away when they showed up and rebooked. So after we introduced the CPMS system, things improved dramatically. Apart from being easy to use and review, there were many other advantages as have been listed on this slide. Staff were trained up very easily and developed little cheat cards and things so they knew when to book long treatments into certain time slots. Chemotherapy charting. So before, like most units that use handwritten chemo charts, there were the issues with legibility, calculation errors, dose roundings causing wastage, missing information. Also, due to the paper booking and fax notification systems, the pharmacists spent a lot of time chasing doctors to get charts ordered so that they could place the drug orders with the external compounder. This whole rush process created many delays, additional error risks, and it was an inefficient process. The chemo orders for the external compounder also had to be handwritten, so that created another high risk for dosing transcription errors. Chemo charting is much less chaotic with the electronic system. Complex treatment pathways are now easily mapped. Clinical alerts are provided for required tests and monitoring. Dose calculation is safe, accurate, and correctly rounded, and percentage of dose change now appears when the dose is changed. Write-ups are now managed as once a week with the advanced training in a pharmacist and take a fraction of the time. The planned order is reviewed on the computer. Changes are made before it's being printed and signed. Once the drug is actually ordered, the chart cannot be changed or modified without contacting the unit. So we've had huge improvements in time, communication, and safety with this process. The scheduler and daily diary are used to plan the write-up, and only evidence-based protocols are available. Anti-medic guidelines are now being consistently followed, and we've also got standardized practice for infusion times and dilutions. Pharmacy verification is simplified, and they no longer need to transcribe chemo orders, as these are automatically generated. Apart from the handwritten notes and the treatment ordering, the consult reviews of these patients often occurred off-site, so the consultant might make a decision that then had to be communicated to the unit at Blacktown, and this relied on fax notification. Similarly, the consultant was not able to review details of the doses given, any reactions that occurred during treatment, or patient parameters. So fax machine breakdowns or paper jams had major safety implications. There was also no automatic uploading of cancer registry information or billing decisions. Although this system had only been piloted at Blacktown, the electronic CPMS was available across the network. Encounter notes were free text, easy to use, and data questionnaires were developed as pop-up links to nursing notes, which prompted recording of patient observations and blood results. All entries were trackable by user login. Diagnosis codes and pathway treatment data could be uploaded into registry databases and reported on for review projects. It was found that the patient medical and medication screens were actually very user-unfriendly, with too many drop-down menus and too much of selection criteria. And although this level of detail can improve data reportability and allow checks for interactions and allergies, recording of these was too time-consuming during a busy consultation, and our doctors were not able to do this. Statistics collection and reporting was streamlined significantly. The CPMS allowed reporting on activity trends resource use, types of treatment, and complexity, and that assisted in service and resource planning. Monthly treatment stats are now able to be uploaded into WebNap for the Department of Health, and the range of reports available seems to be infinite, and we're sort of only at the tip of the iceberg at discovering what we actually can retrieve from the system. The report setup is also fairly dynamic and allows quite a range of new reports to be set up. So, barriers and limitations. Although this system had been used nationally in Queensland and many other hospitals in other states, we were the first in New South Wales to take this particular system on, and that came with disadvantages. We were also the first site nationally to try and use it as a full electronic record, with other centres mainly using it for the chemo charting, pharmacy and scheduler functions. Training time or lack of training time was a major limitation, and again depended on the computer literacy of the staff member and their openness to change management. Manual data entry was significant and unplanned for, and this was compounded as we had no assigned full-time project staff, so all the workload was basically added on to the current workload of the people involved in the project. We were also limited by IT and Department of Health policy and procedures and had to plan infrastructure and equipment purchases. Management of simultaneous workflow changes was difficult, even though we had a very small unit to start with. We needed buy-in from all the staff and maintaining motivation in a busy clinic environment. But we did learn a few lessons, and hopefully some of these will be used to help us when we go with the implementation at the bigger sites. So the next steps for Blacktown, we are going to introduce the Cerner interface for uploads of clinical chemistry and hematology results and start a regular process of downloading read-only information into PowerChart, especially for emergency department admissions. We're looking at PBS script management, which is being trialled at this time. And as we've recently introduced clinical trials to the unit and there's major expansion planned, the CPMS has a lot of trial support functions to offer, which will be looked at. Cancer registry and tumour staging data entry is also the next stage, and we're currently in the process of reintroducing a modified medical and medication history data entry and working with the vendor and our medical staff to improve this process. We've had submission to Department of Health to use full electronic prescribing with digital signature so that we can go paperless in the future. There is currently building and design planning for the new Blacktown Cancer Centre, which will have wireless availability, and we are planning for a complete paperless system with tablet PCs at the chairside entry for notes, chart checking and digital signing off by nurses. So in conclusion, the CPMS implementation at Blacktown Oncology Unit has improved communication, enhanced patient care, treatment safety and streamlined our workflow practices. It has assisted in planning for service enhancement and clinical network integration. The new cancer centre that's planned for Blacktown will have double the treating capacity, and with radiation oncology and other specialties coming on board, there's going to be radical increases in staffing and numbers. And I've just got a couple of acknowledgements. Thank you very much for your time.
Thank you, Deirdre. We have time for one quick question.
I'm Sally Crossing from Cancer Voices New South Wales. We're the voice of people affected by cancer in our state. This is music to our ears. I think it's absolutely wonderful. Congratulations. I very much hope it will be rolled out further. I mean, it's amazing to think that this sort of thing doesn't exist already. So thanks for being the pilot people.
Thank you.
My particular question is, cancer patients are very interested in having handheld treatment and care plans. I was wondering whether out of this seems to have all sorts of possibilities, that sort of thing could be generated.
One of the things that we can do from the scheduler is print out patient calendars, which is what has been happening. So again, instead of having little cards and bits of information where we give patients so they remember their next appointment, they can actually see their next 6 appointments now printed out for them. And rescheduling is also very easy with the system. So if they tell the staff that I can't make that particular day, that something is in the way, we can reschedule very easily as well. So it's much more improved compared to the old systems.
That sounds really good, but what we're looking for is a little bit more, where you actually know what drugs you're being
Oh, absolutely. A medication list is another big problem, and that's something that even at a big hospital, I work at Westmead Hospital, and staff limitations are our biggest problem with making sure all the right people get a medication list and a history. So it's definitely a problem, and hopefully this might help us.
The more electronic we get, the more
Yep,
likely we get.
absolutely.
Thank you.
Thank you.
Thank you. Next, we have Jenny Rutherford she's the gyneco-oncology cancer care coordinator at Hunter New England Center for Gynecological Cancer. Jenny, she's going to speak about gyneco-oncology telehealth.
Thank you. My name's Jenny Rutherford. I'm the Gynae-Oncology Care Coordinator based at the Hunter New England Centre for Gynecological Cancer in Newcastle. In June 2011, we developed guidelines for a telehealth initiative involving video link new patient consultations, and in August 2011, we commenced this service for women with or suspected of having a gynecological malignancy. I'd also like to thank Dr. Jeffrey Otten, gynecological oncologist, and Kath Adams, our senior clinical psychologist, who've both been involved in this initiative. For those who aren't from this area, Newcastle is 160 kilometres north of here, and we're very proud of our beaches. This is the entrance to John Hunter Hospital, where our unit is based, and that's where the gynecological surgery is performed. And this is the Mater Hospital, which is about 10 minutes away, where most of our patients have their chemotherapy and radiotherapy. The aim of our telehealth initiative of new patient gynae-oncology consultations is to provide a comprehensive specialist consultation, including psychosocial screening, emotional support and information provision as standard treatment, while saving the patient travelling long distances to Newcastle. As with any change to cancer care provision, we need to be aware of fulfilling the domains of the New South Wales Cancer Plan. The new Cancer Plan for 2011-2015 has a focus on improving models of service delivery, and we believe that our telehealth initiative closely aligns with this and helps to achieve this goal. On average, 10% of patients coming to our unit travel more than 300 kilometres to meet with their specialist gynaecological oncologist to discuss management and treatment of their presenting symptoms. As a result, women and their families have been forced to travel many hours to attend a new patient consultation. This is not only time-consuming but provides significant financial and emotional strain on patients and their families, also burdening the IPTAS funding and hospital accommodation facilities. So to save the patient and their families the inconvenience of travelling to Newcastle, we've established the option of video conference new patient appointments for some of our patients. Initially, we commenced these consultations with Tamworth Base Hospital, which is about 4 hours away, and once that process was well established, we then broadened the service to Coffs Harbour, Port Macquarie, and as of yesterday, Moree. The red dots on this map indicate the sites already established, and the purple dots indicate the sites where we'd like to expand to. The yellow stars indicate where the patients to date have been coming from. So just to give you an idea of the time and travel savings to our patients, we could drive from Sydney to Perth and back 3 times on the distance not travelled by our patients to get to these consultations. We've saved each patient from around 3 hours to 13.5 hours in travel time by providing this service. Since commencement of this service, we have had the following consultations: 18 patients from Tamworth, 13 from Coffs Harbour, 2 from Port Macquarie and 1 from Moree yesterday. The average age range of our patients is from 44 to 91. This is a fair age range, and the average age is around 63, which is the average age for female cancers. 3 patients did decline the option of video conference appointments, although interestingly 1 was from Armidale, 1 was from Moree and 1 was from Gunnedah. So all of these patients still had some travelling to get to Tamworth, and in fact Armidale and Moree are on our suggestion list for inclusion in the future. 1 patient declined because she had family in Newcastle, so wanted to come down anyway, and the other 2 declined just because they couldn't understand how a consultation like that could just work over the computer. despite my lengthy explanations. The 2 patients who were not suitable required examination. I'd also like to point out that these appointments are made, the patient's given the option of coming down to our unit or having the video link. Their appointment time and date is exactly the same whether they were to travel or not. We see numerous benefits from providing this service. Firstly, cost savings to the patient and their families and to the IPTAS funding service. Reducing stress. We all know patients presenting to an oncology service experience significant stress and anxiety, and the need to travel to an unknown place just adds to this stress, particularly for our women, many of who are older. Linking patients and families with supports and contacts within their local communities is a priority for all specialist cancer services. Video consultations where the patient initially attends in their local oncology unit allows the patient and their family to meet the nurse coordinator at an earlier time. The local nurse coordinator is best suited to assist the patient and their family with issues and needs that they may have before or after treatment at their specialist facility. As well, should the patient require adjuvant or neoadjuvant treatment at their local oncology unit, this transition can be streamlined, again reducing stress for the patient and their families by showing them the close relationship between their specialist facility and their local oncology unit. We've also found that by offering this service, we've been able to arrange for patients to discuss the option of participation in clinical trials not offered in rural centres, improving equality in service provision. So how have we achieved this? Video conferencing equipment has been provided by our local health district at John Hunter Hospital and also at Tamworth in existing outpatient clinic rooms. Existing equipment has been used in Coffs Harbour and Port Macquarie, currently used for the MDT meetings. We use that facility. Because there's no need for consultation, the room just needs to be private and secure for somewhere the patient and the coordinator to sit. Referrals are carefully triaged by myself and our team to ensure that a video conference is appropriate for that patient, and is usually ensure that all diagnostic imaging and tests are completed and available. The referral is received and the appointment's arranged in conjunction with the rural care coordinator. The patient is contacted by myself to have the procedure explained, and then the local staff contact them as well just to let them know where to go. As you can see from this photo, the patient can clearly see the staff via the video link. At the appointment, as well as the patient having their usual consultation with their specialist and have the opportunity to ask questions, they complete our usual psychosocial and nutritional screening tools, which are faxed to us just prior to the appointment. If required, they can also meet with our clinical psychologist following the consultation. They're given all disease and contact information as usual. They sign their consent for a procedure, which is faxed back to our doctor completes it. We fax it to them, they sign it and fax it back. They complete the usual request for admission paperwork, which is faxed back to us, and admission planning can begin following the consultation. In Tamworth, the pre-op clinic have been very supportive and helpful by actually seeing our patients in their pre-op clinic prior to coming down. Whereas at Coffs Harbour and Port Macquarie, the patients have been coming down a day prior to surgery to meet with the anaesthetist. At the inception of these clinics, our first priority was to provide the service with our gynae-oncology specialists. However, once established, we became aware that there were much broader opportunities. While regional areas such as Coffs Harbour and Port Macquarie and soon to be Tamworth offer external beam radiotherapy, some of our women require primary or adjuvant volt brachytherapy, and the women are still required to come to Newcastle for this. So as there's no SIM-CT planning appointments for this, and the radiation oncologist doesn't necessarily need to examine them, teleconferencing is a very suitable way for these women to meet with their radiation oncologist and have that treatment explained, consent signed, and again saves them a trip to Newcastle. Also, one of the patients who did meet with the radiation oncologist, she was actually an 88-year-old lady who had the discussion with the rad-onc just regarding the MDT's decision for her not to have any further treatment. So that was a very valuable experience for that patient and the family to have that explanation explained by the team member who actually made that decision, and the family were very appreciative of this. And the patient who saw the medical oncologist was in regard to recruitment on a clinical trial. So problems that have occurred, no system occurs without problems. Our main concern when initiating this was to ensure that patients weren't coming down to have surgery and problems being with, surgery times, etc. We've only had one patient who, upon examination on the day of surgery, was felt to be not suitable for laparoscopic surgery and would therefore need open surgery. And as there was no high dependency unit bed available on that day, her surgery needed to be rescheduled to the following week. We also had one issue of a video link with Coffs Harbour when we thought we were going to need to do it just by phone alone, but just as we started, the picture appeared, so that problem solved itself. As with all services, there are also limitations. Obvious difference with this is that a physical examination cannot be attended. So this means that the referrals need to be very vigilantly checked to ensure that this type of consultation is appropriate. And also extra information that we don't normally need regarding operation reports from previous surgery is required for the specialist to make the decision about whether laparoscopic or open surgery is appropriate. These consultations can only be used for initial consultations, not follow-up, as follow-up patients require examination. These consultations do take a little bit longer. We actually allow an extra 15 minutes for the appointments, just allowing faxing. Sometimes fax lines are busy, and also the conversations just tend to take a little bit longer. And while we're streamlining the process, we feel that this it has been necessary. As with any IT system, we rely on the technology to be functioning and working. As these appointments broaden, we're limited to the number and availability of the technology. At the moment, we only have one clinic room set up with this facility, and I can see that in the future that we may, it will be a benefit to have more of these facilities available. We see it as essential that a nurse coordinator is present to support the patient and their family, and we're thus limited to their availability also. It's preferable that the coordinator has an understanding of the treatments to discuss to be able to adequately support and assist women and their family. The roles and responsibilities of coordinators are very diverse between units. However, all the coordinators have been very cooperative and enthusiastic in helping set up this unit and arranging their appointments. It does actually limit where these facility can be broadened to by needing a care coordinator on site at that facility. So we have surveyed all patients who have undergone these teleconference appointments. We sent out a pencil and paper questionnaire and out of the first 28 patients, and we got a 75% response rate. We asked all patients to rate their teleconference on a 5-point scale. As you can see, there were no negative responses, 1 neutral response and 20 positive, including 3 people who inserted their own score of 4.5. We also asked the patients to answer 3 simple questions about the service, if they felt they received enough information, if the time allocated was sufficient, and if they would recommend this type of consultation to anyone else. And overwhelmingly, they all said yes to these questions, which was a very, very positive response. So I also just asked for some comments, and these are a few of the comments that they gave us. One husband actually said that he felt that more time, that the doctor was actually more focused on him and his wife than he felt possibly may have happened in a normal clinic situation. There were no interruptions. I always put a big teleconference in progress sign on the door, which, contrary to other consultations when people are knocking on the door, borrowing the doctor for a minute or two, with a big bright pink sign on the door, teleconference in progress, no one seems to interrupt. So that is a benefit to the patient as well. There were 2 comments that the patients made suggesting improvements. One was just in one of the rooms, we need to pull a screen across so that they could actually see us better. It was just a bit light. And also the other day we got the comment afterwards that the doctor needs to sit a bit further back because we could only see half his face. That was at our first teleconference with Port Macquarie, and it does show you need to, the camera can just be twisted slightly to the other side, and you just got to check that, you know, often the patients won't say, well, you know, we can only see half your face. So just checking that's okay. So where to from here? We'd like to broaden this service to Moree, which we just did yesterday, and Armidale. I've actually got one booked in for a week Monday at Armidale, and then Taree. So we'd like to increase the access for medical oncology and radiation oncology appointments where they're appropriate. We'd like to liaise with the Aboriginal Liaison Officer to improve access for our Indigenous women to our gynae-oncology services, and particularly by establishing the link in Moree, we feel that this should be achievable. We'd also like to ensure that the establishment of permanent funding for the nurse coordinators to allow this service to continue and expand. And we would also like to extend the service to provide psycho-oncology consultations with our clinical psychologist who's based at John Hunter Hospital for new patient and also follow-up consultations. And now that the technology is there, we see that that's very, very possible. And thank you.
Thank you, Jenny. I think we're actually out of time, so I hope that you ask questions to Jenny when the session is finished. We need to go to our fourth oral presentation, which was Marita Timpany, who's the nurse unit manager at the Oncology and Palliative Care Services at Daffodil Cottage. And she's going to talk about telehealth medical oncology service in Bathurst.
Hello, thank you. I think I'm following on the back of the other speakers, particularly Jenny, about our telehealth service at Bathurst. Just to give you just a little bit of information about what Daffodil Cottage is and where we are. We're based in Bathurst, which is west of Sydney. It was a purpose-built cottage, and it was built by generous donations from the local community, so it has a lot of community input into the facility and how it runs on a day-to-day basis. We were also successful with getting $100,000 on the day to actually establish the cottage, and that was donated by the government of the day. So the cottage opened in 1996, so it's been going for a number of years. Our aim is actually to provide holistic cancer care to the local community, which enables patients to be able to have their treatments at home and stay close to family and friends. And we also provide care and support to their carers and their family members. Now, over the years, the cottage has experienced some difficulties with funding, staff shortages, and the usual things that happen in country areas. Just to give you an idea of our client base, we actually service people in the local area as well as the city of Bathurst. So we would service people as far as Ralston, Mudgee, Blaney, patients from Cowra, Black Springs, and this just gives you an idea of some of the area. So even to come to the cottage, some patients are already travelling 170 kilometres just to come into the cottage to avail themselves for treatment and for reviews. So our philosophy was to give quality care to patients, and this was done with a holistic approach, and we wanted to maintain clients' individuality and to encourage and support each client's cultural, religious and spiritual beliefs. The services that the cottage provides is oncology services, including haematology services. So we would offer a full range of chemotherapy protocols. We also have a palliative care service. We offer care coordination, oncology counsellor, and we have a range of cancer support groups and services. So the cottage, as I said, was built by the community, has a lot of community ownership, and they run a lot of groups there that support the patients. They would run breast cancer support groups, prostate support groups, encore bereavement support groups, and also a general support group. And we have a really large volunteer base, which is made up of more than 30 volunteers that would be in on any one day. We would have 2 volunteers scheduled, and they supply the patients with morning tea, afternoon tea, lunch and things like that. They also support the staff as well. Often we don't even get a lunch break, so often they're running out getting us our coffees and lunches as well. So the team at the cottage, at the moment we have telehealth, which we've just commenced, which I'll go on to speak about. So we have telehealth medical oncologist, we have a visiting radiation oncologist, specialist oncology nurses, a care coordinator, a breast care nurse, so a McGrath breast care nurse, a specialist palliative care nurse, a palliative care CNC, a palliative care occupational therapist, palliative care social worker, and again, as I said, our vast list of volunteers. So for 2011, our clinics, we had 1,836 patients go through our clinics. This equated to 1,700 chemotherapy treatments and 1,200 palliative care visits. So our occasions of service last year were 4,758. So beginning of 2012, we actually had a visiting medical oncologist to the area who retired. And this medical oncologist provided a service to the patients of Bathurst for the last 25 years. So when he announced his retirement, it sent, you can imagine, ripples right across the area. So all of a sudden we were left without a visiting medical oncologist. The local health district was quite successful in recruiting 2 medical oncologists to Bathurst and Orange, but they're not able actually to start until 2013. So we were left with this real hole in our service, and what will we do for our patients? So what we actually did was we had to actually get patients to travel to Sydney for consultations. So the first hospital that came on board to support us was Nepean Cancer Care Centre. So we would organise accommodation, transport and the various things that go with that to get our patients down there to clinics. Now, Nepean were very good. They actually put on 2 afternoon clinics each week, on a Tuesday afternoon and a Wednesday afternoon, for new patient consults as well as patients in follow-up. We have patients going to a number of other hospitals, including Westmead, Concord, St Vincent's, Royal North Shore, Prince of Wales and RPA. So we've got patients who just were referred to all these other Sydney hospitals, depending on whether they had family locally in those areas in Sydney. But they would actually come back to the cottage to have their treatment. So patients, in particularly a lot of the Sydney hospitals, would be reviewed between each chemotherapy cycle. So they would be travelling to Sydney at least once every 3 weeks. Now, as I mentioned, some patients would travel 170 kilometres just to avail themselves for treatment at the cottage, and then to actually go further to Sydney for a doctor's appointment for reviews, they would travel anything up to 300 kilometres. And I think it was, as Jenny said, the financial burden that was placing on families, the emotional stress was quite considerable. We had patients who felt, it was just too much. And so we had a lot of, toing and throwing and trying to work out how we could accommodate them and really encourage them to continue on with their treatments. One patient, a young patient of ours, was already travelling 3 hours to get to us for treatment, and then 3 hours to get to Sydney. Her parents would have to accompany her, so that meant that they would have an overnight stay, and it was loss of work and things like that. So the pressure and the burden on families, is really great. So what happened was the local health district was very fortunate in getting a grant. It was a statewide service initiative to actually purchase some video conferencing equipment. And this is brand new to us, so that we applied for the grant and we were successful in getting it. So that began our journey down the telehealth clinics. So we commenced video conferencing, and we commenced in June this year, so it's only brand new to us still. It's only a few months in. The first person to approach us was Professor Della from the from Campbelltown Cancer Therapy Centre. He's the director there, and I think he's here today. It was much appreciated. A phone call from him saying that he would like to offer his services to help us out. So when the video conferencing equipment arrived, we made sure that a unit would be sent to Campbelltown so we could access Dr. Della. Also, Nepean were to have a unit sent to them, and the other unit was to go to St Vincent's. So MacArthur came on board first, as I said, in June, and then it was followed by Professor John Greigel, who was our retired oncologist. He's consented to seeing patients of his that are still in follow-up. So we do that through St Vincent's Hospital, through their established teleconferencing link. Now, a wide range of consultations are offered, from new patient consultations, chemotherapy consultations, so as follow-up consultations, treatment plans and decisions, and sometimes just some general advice. Now, the video conferencing technology also provides a great opportunity for educational opportunities for staff, and Dr. Della has a link with the University of Western Sydney. Their fourth year medical students actually have access at Bathurst, and they will actually come in and sit in on his clinics for education as well. And in some cases, they'll actually examine some of the patients to give them a little bit of clinical experience. And we're looking at the possibility of this equipment being used for discussions with MDT teams across the area and across the state, and also just, to follow different tumour streams. Now, to get the telehealth clinics going, we had to put a process in place to get the patient's clinical history, their medical record, all their diagnostic results, and any treatment developments and reviews. We had to get all the paperwork together and work out how we were going to run these clinics. So what we did was all the patients, if they're new patients, obviously their referral and all their notes was scanned. We set up a generic email account between the centres and myself, so that we didn't have, anyone didn't just have access to those emails that came through to myself. So what we did was all the notes were scanned and sent to the appropriate sites. Any patients who were in follow-up or who were seen at the consultations who need medical imaging or pathology, it's all done. We try to have it all done locally so that the doctors can have access to it. And how they have access to that is we use the Tamberg video conferencing equipment, and so the doctors can actually see what we actually put up on the screen. So we can go through Power Chart, clinical patient folder, Merlin Web. I don't know if anyone's familiar with that. That's the medical imaging program that can be accessed through the PC. So we can actually put that up on the screen so the doctor at the other end can view the CT scans, the pathology results, the clinical patient folder. So because we scan the medical record, they can actually view the clinical patient notes if required. The other way of doing it is the doctors at the other centres, if they have access to these systems, they can actually view them up on their own screens themselves. Now, the role of the oncology nurse we've found in this has been quite vital. We do have a care coordinator as well, but because most of the patients are actually actively having treatment, and we following them very closely, we felt that the oncology nurse on the floor who's been in on the consultations and the treatments on a daily basis is needing to go in with the patient. And this is actually to discuss any problems that they might be having, and just to give a lot of background to the doctor on the other end prior to the patient coming into the room. So we've found that to be a better system for us. After the consultation, we would then link them in with the care coordinator for any other tests and any other pathology or anything that they may require. And coming from a Sydney hospital and going to a country area, the challenges are quite great because we actually don't have a doctor at all on site. So the doctors really rely on the nurses, particularly in the video conferencing, to really be able to give them a good comprehensive history of what's actually going on with the patient. We have, when the patients are seen in the telehealth clinics and the doctor gives them, talks to them about the prognosis and the possibilities of treatment, we would then access EverQ for patient information, which we would give to the patient. The chemotherapy order is scanned by the doctor at the other end and would be scanned back, and so we would have that within 24 hours. So for us it's worked very well because of patients going to other multiple sites, chasing charts and chemotherapy orders in a timely manner is quite hard and very time consuming. So we've found this for us to be, very beneficial. And we're looking at possibility in the future across the area that there might be a role suited for a nurse practitioner because we literally, don't have access to medical staff currently. Thank you.
Thank you very much, Marita. Please ask Marita questions at the end because this is now the end time of the session. Appreciate everybody being here.